How do we treat these patients who are having community-acquired lower respiratory tract infection? First, we have some rules. The choice of the therapeutics depends on the signs of severity, the etiological orientation elements, and especially the term. We have to begin with an probabilist antibiotics at first line. Then we could change it depending on the microbiological documentation. Antibiotics must be initiated as soon as possible, and then we evaluate the patient 48 to 72 hours after that to see if the treatment is effective or not. The oral intake should be preferred when it is possible. We do not have to forget about the symptomatic treatment. If a patient has a productive cough, we could give him fluidiferous and mucofluidiferous like Muxal. If he has a dry cough, we do give him antitussives like Akindex. If he has fever, we do give him antipyretics like Doliprane. If he has a low saturation rate, we do give him oxygen therapy. For young children and elderly patients, we could have some deshydratations. We do have to give a rehydration and hydroelectrolytic rebalancing. And of course, we have to correct the hemodynamic disorders. What about antibiotics? We have three big families, what we call beta-lactamines, macrolides, and quinolone. For beta-lactamines, we have the amoxicillin that we have to give 3 grams per day. For example, amoxil 1 gram. Amoxiclavulanate for the germs that are secreting beta-lactamase. We give 2 to 3 grams per day. For example, Levamox 1 gram. Cefotaxime 4 grams per day. Clafuron. Ceftriaxone 1 to 2 grams per day. Rocefin 1 gram. Erythromycin 2 to 3 grams per day. Eri 500. Spiramycin 2 pills per day. Rova 1,5 million. Roxystromycin 300 mg per day. Relié 300 mg. Azithromycin 500 mg per day, like Azix 500 mg. And for quinolones, we have ciprofloxacin 1 gram per day, like Cipcin 500. Ofloxacin 400 to 600 mg per day, like Oflocid 200 mg. Levofloxacin 500 mg per day, like Efloxin 500 mg. And moxifloxacin 400 mg per day, like Zilex 400 mg. And we have to know about the effectiveness of these antibiotics depending on the germs. For example, for streptococcus pneumonia, the amoxicillin, amoxiclav, and ceftriaxone are effective on this germ. But the macrolides are not really effective, so we do not have to give macrolides if we are suspecting a pneumococcus. The related to macrolide like pristinamycin and letromycin are effective, and the fluoroquinolone antipneumococcic like levofloxacin, they are effective on that germ. For Haemophilus influenzae, the amoxicillin is not effective because this pathogen is secreting beta-lactamase. So the amoxiclav is effective, ceftriaxone also, and the fluoroquinolone antipneumococcic, they work. For atypical germs like Mycoplasma, Chlamydia, and Legionella, the most effective antibiotics are macrolides, related to macrolides, and fluoroquinolone antipneumococcic. And the amoxicillin, amoxiclav, and ceftriaxone doesn't work. They don't work at all. So, if we have an outpatient treatment, if we suspect an acute bronchitis, we do not have to ask for chest X-ray and we do not biological exam. We have to give the patient just symptomatic treatment, no antibiotics, because mostly these infections are due to viruses, and exceptionally, if we have a persistent cough with expectoration more than 7 days, we could give him macrolides or sticklines for 5 to 8 days. What about pneumonia? We do the chest X-ray of course, but we do not do biological or bacteriological examinations. For healthy subjects with no sign of severity, if we suspect pneumococcus, we do give amoxicillin. If we suspect atypical bacteria like Mycoplasma or Chlamydia, we give macrolides. And for elderly subjects or young subjects with comorbidities, but without sign of severity, because if we had sign of severity, we have to hospitalize these patients. In that case, we give amoxicillin, clavulanate, or levofloxacin or ceftriaxone. What about hospitalized persons? If we had pneumonia, we have to ask for laboratory examination, CBC, inflammatory markers, looking for arrays of CRP or leukocytosis. We do ask for some kidney tests like urea, creatinine, and angiogram, and liver function tests also, looking for some signs of severity. We do ask for microbiological exams like blood cultures, sputum cultures, PCR, Legionella and Pneumococcus antigenuri, which we can find in the urine of these patients. And we could also do other examinations like endobronchial aspiration, especially for children, pleural function if we have a pleural effusion, and even bronchoscopy. So how we do the sputum culture? In the morning, while fasting, after rinsing the mouth, the patient have to do an expectoration and not a saliva, and we put it in a sterile bottle. Then we have some criteria of a good expectoration. We have to have more than 25 neutrophils and less than 10 epithelial cells. And the culture will be taken into account if we have more than 10 million germs per milliliter. The performance of these tests should not delay the initiation of antibiotic therapy, as we have said first, because we have to begin as fast as possible antibiotics, and it will be probabilist at the first line. So, as we have said, the most common germs in these infections are pneumococcus, mycoplasma, and Haemophilus influenzae. But the most common germs in the hospitalized persons are Legionella, gram-negative bacilli, and Staphylococcus. So we must broaden the spectrum of antibiotics depending on these germs. So in hospitalized persons, we have to give amoxicillin or amoxiclav or ceftriaxone associated to macrolide or to a levofloxacin, which is a fluoroquinolone anti-pneumococci. These treatments have to begin administered by injectable way for 48 to 72 hours. Then we pass to the oral intake. The whole duration of treatment is from 7 to 40 days, and we have to evaluate the patient clinically after 48 to 72 hours, but the radiological evaluation is done 4 to 6 weeks because the chest X-ray takes some time to get back to a normal. So what we have to do if you have no clinical improvement after 48 to 72 hours of antibiotics? We have first to look if the patient is taking well his treatment, the compliance of therapeutics. If he is not vomiting the treatment or having some absorption disorder. If the germ is not sensitive to the antibiotics that the patient is taking. If we have a complication like pleural effusion or abscess, or even if the diagnostic is not correct. So what we have to do if we have that no clinical improvement? If we have no worsening, he is stable, we do change the antibiotic. But if we have a clinical worsening, we have to repeat the chest x-ray looking for these complications, to assess the patient, to even ask for a scan, an endoscopy or angioscan looking for another diagnosis, and all that depending on the context. What is the prognosis of these infections? The mortality increases with age, and we have a specific score that allows us to evaluate the risk of mortality. That's the curve 65 score. If we have a score of 0, we have 1% risk of mortality. The score between 1 and 2, 10% risk of mortality. Score 3, 40% risk of mortality. And score 4, 40% of risk of mortality. And prevention. In specific cases, we have to do a vaccination of patients. And the first vaccine is the pneumococcal vaccine. We have the Prevnar. We have several subfamilies of pneumococcus which are responsible for infection. And we have especially pneumococcus 13 and pneumococcus 23 who are responsible for respiratory infection. So we do have to vaccinate the patient against these two subfamilies. We have the Prevnar against the 13, then we give the pneumovax against the 23 to 8 weeks before giving the Prevnar. And we give these vaccine for patients aged more than 65 years who had antecedent of pneumonia. We have some dementia, epilepsy, cardiac insufficiency, some immunodepression like splenectomy, diabetes, COPD. Also, we have the influenza vaccination because we have talked about the viral infection that are also seasonal and common and are responsible of some epidemic problems. And we do have to vaccinate patients by vaccine grippe once a year, and it is indicated for elderly subjects, the ones who are having some chronic respiratory disease, diabetes, chronic renal failure, for also healthcare person and a person who have positions of responsibility. Of course, if a patient is a smoker, he has to stop smoking because it allows him to have a better immune system and to go against these infections.